can go ahead and begin with some introductions while others are logging on. Thank you so much for being here today. My name is Elena Dinkin, and I'm the Senior Adult Director here for the YMCA of Greater Houston. And it has been really a pleasure and great fortune to be able to partner all this time with UTHealth Neuroscience. During COVID, they've gone beyond, and each month we've had a very valuable informational talk from a physician. Today I know will be just as great. So again, thank you so much to UTHealth Neuroscience, and I will ask that Hillary go ahead and make some introductions too. Thank you so much.
Thank you, Elena. Thank you everyone for being here. I'm a member of the UTHealth Neurosciences team, and for background, UTHealth Neurosciences is the largest provider of neuroscience care in the region. Today, you're going to be joined by neurosurgeon, Dr. John Caridi, who will discuss conservative treatment strategies, as well as surgical procedures that can help to alleviate and treat back pain associated with spine deformities that can develop or worsen as we age. Just a reminder that if you have questions, please put them in the chat below, and we'll get to as many as we can during the Q&A at the end of the presentation. I'll also be putting our contact information within the chat in case you have follow-up questions or if you'd like to learn more about us. And with that, I'll pass it along to Dr. Caridi.
Thank you very much. And thank you for allowing me to speak today about low back pain and spinal deformity. As Hillary mentioned, I am a neurosurgeon who specializes exclusively in the care of spine ailments. So low back pain is an extremely common problem. 80% of people will seek medical attention at some point in their life regarding low back pain. This is the second leading cause for people to visit an emergency room behind chest pain. So I just want to quickly go over the structure of the spine. So there are 5 bones that make up the lumbar spine, and each one is separated by an intervertebral disc. A collection of nerves travels through a canal made up of the bones, and an individual nerve travels through a small hole in the bone that then travels down into the legs. The disc itself is made up of a thick outer rim with a soft core, which is somewhat gelatinous. Then there are also 2 joints between each bone, and this allows us to continue to be mobile. There are also a complex musculature array that binds each bone together and allows the spine to move as a complex, and these are referred to as the erector spinae complex of muscles. There are actually multiple individual muscles that act to do several things, and this is one of the root causes of a lot of back pain that we see. So there are 7 cervical bones, 12 thoracic, 5 lumbar, and these sit on top of the sacrum and pelvis, which were initially multiple bones, but then fuse as time goes on. This is a view from the side. These are the holes where the individual nerves are coming out. And then this is the back of the spine, and then you see the individual joints between each one of the bones in the spine. So when someone comes to see us complaining of lower back pain, the first thing that we need to figure out is exactly what it is that's causing the pain. Every single structure that I talked about can cause pain in the back. So it's vital to figure out which one of these is the cause, because each syndrome is distinct and each treatment is different. The most common problem is a muscular strain. This is generally caused by a small tear in the musculature or the tendons It can be on one side, it can be on both sides. It generally is associated with overdoing it or a maneuver that is very awkward. This is a self-limited problem, meaning it will go away on its own. It's best treated with physical therapy. If therapy is unable to satisfactorily relieve the pain, often our pain management colleagues can do trigger point injections into the region where that muscular strain is to help relieve a lot of the inflammation that's occurring. Another large component of back pain is facet joint arthritis, or another term for that is facet arthropathy. This refers to the joints between each one of the bones. And these joints will develop inflammation and that inflammation will then cause an overgrowth of the ligaments and the bony structures. What the typical syndrome we see with this is that you have pain after prolonged inactivity, such as sitting for a long period of time or sleeping. So people generally feel very stiff when they wake up in the morning, and this is typically relieved with walking or stretching. If this continues to be a significant problem, this can be treated by our pain management colleagues with what's called a facet joint injection, in which medication is delivered directly into that joint, or what's also termed a radiofrequency ablation, in which the tiny nerve that innervates the joint is essentially burned in order to help relieve that pain. As the bony structures, if they grow abnormally and the ligaments continue to grow abnormally, that can lead to narrowing of the canal where the nerves are. And very rarely, a cyst can form coming off of those joints. And that cyst contains fluid from the joint capsule, and occasionally that would require drainage or surgical intervention in order to relieve any symptoms caused by that cyst. Another very common thing we see is called an annular tear. So the annulus fibrosus is the thick outer covering of the disc. The nucleus pulposus is the soft inner core of the disc. What typically happens in this scenario is our patient has some trauma of some kind. They have a fall, or they have an awkward maneuver, and they feel sudden severe low back pain. They can sometimes feel pain in their legs. They notice this pain more with significant activity. This is another problem that is not treated with surgery. This is another self-limited problem that will eventually get better on its own. It's treated best with physical therapy, and occasionally can be treated with an epidural steroid injection, which our pain colleagues can deliver directly into this region in order to stop the inflammation that is causing all of this pain. Another very common cause of pain is inflammation at the joint where the spine and the pelvis meet. So this is referred to as the sacral iliac joint, because the joint is between the sacrum here and the ilium, which is the large wing, which people often refer to as their hip. This is a cause of up to 30% of their back pain that we see. Patients generally have pain with sitting for prolonged periods of time. They can have numbness and pain in the leg on the affected side. It's generally very, very tender to touch, and people sometimes have significant difficulty crossing their legs or lifting their legs. This is treated generally with anti-inflammatory medication, and It is also well treated with physical therapy in order to help alleviate that inflammation and strengthen the muscles in this region. Occasionally, an injection into this joint is required in order to relieve the inflammation, and very rarely patients require a surgical intervention to fuse the joint or stop the motion in that joint completely. So another somewhat common cause is disc herniation. So this refers to a fragment of the nucleus pulposus, which breaks free from the native disc and tears through the annulus fibrosus and enters the spinal canal, compressing a nerve or causing stenosis or narrowing of the canal where the nerves are. This can cause severe back and leg pain. On rare occasions, it causes dysfunction in the nerves that control the bowel and bladder, as these all travel through that region. That's referred to as Cauda-Equina syndrome. If that occurs, that's a surgical emergency and has to be dealt with immediately. However, if a patient has back and leg pain, the body eventually will destroy the piece of disc material that's causing the problem and will heal the tear where that fragment came from. So very commonly, patients with disc herniations can be treated with epidural steroid injections. If they are unable to gain relief from the epidural injections and with continued physical therapy, they may require a surgery in order to remove that fragment of disc material. This is a very small surgical procedure that's generally a same-day operation and helps to relieve the pain in the back and the leg. A very common problem that we see is spinal stenosis. This is caused by a combination of annular bulging, or as the disc collapses, the thick fibrous outer layer of the disc will start to protrude into the canal, as well as what we term as facet hypertrophy, which is that abnormal overgrowth in the joints between the bones. That combination causes the narrowing of the canal, which is what we refer to as stenosis. This per se does not cause back pain, but causes mostly leg pain, particularly with walking. Patients who have significant stenosis feel pain radiating through the back and outside part of the legs and into the feet. That pain is generally relieved by rest or walking in a bent over posture, such as using a shopping cart and leaning on a shopping cart, and that helps to alleviate the symptoms. When we see patients with this problem, we generally start with a conservative approach and have patients complete a course of physical therapy, as well as possible epidural injections in order to help relieve the inflammation. If they're unable to gain any type of relief from non-surgical treatment, they may require a surgery in order to take that pressure off of the nerves. That is generally accomplished by removing the back portion of the bone, as well as all the overgrown ligament, freeing the nerves and allowing them to regain their blood flow and do away with the inflammation that has been causing the symptoms. Another common problem that we see is called a compression fracture. This is a result of a trauma. So the compression fractures appear in the vertebral body, which is in the front portion of the spine. The trauma could be minor. It could be as as minor as just falling and from a standing height. And what we see on an X-ray or MRI is the loss of height of that vertebral body, and sometimes a wedge-shaped deformity of that vertebral body. This is a problem that is typically treated well with rest and non-steroidal anti-inflammatory medications. They help relieve the pain while the fracture itself heals. It can take up to 3 months for these fractures to heal. If the pain is intractable and there is a sign that the bones are not healing properly, patients may require what's called a kyphoplasty, which is a procedure where a small amount of thickening material, or what we term cement, is injected percutaneously or very minimally invasively into the vertebral body, and that helps regain its height as well as stop the motion that is causing the pain from the fracture. Spinal instability is the most common surgical cause of back pain. So this refers to a patient whose spine is moving in an abnormal fashion. It's caused typically by a disruption in the disc that then causes arthritis in the facet joints. And over time, that disc begins to basically slip forward as gravity pulls the patient forward. And you can see how the bones start to abnormally line up. And as they abnormally line up, the nerves within the canal begin to be more and more compressed. This can also be caused by a chronic fracture, which is generally seen in younger people. And this type of instability is termed spondylolisthesis. It's one of the leading surgical causes of low back pain and leg pain. When this is seen, while we always try conservative management first, surgical intervention is typically required when we see this type of problem, particularly with these higher grades of slippage. The surgery that is required for this has to accomplish two different things. The first is to take the pressure off of the nerves that are being compressed, as well as to stabilize those two bones and bring them into a more normal realignment. The stabilization is called a fusion surgery, and a fusion basically stops the motion completely between those two bones and makes them into one contiguous piece of bone. I just wanted to touch on degenerative disc disease. So this refers to a loss of water within the nucleus pulposus, or that central portion of the disc. That leads to collapse and then bulging of the annulus, which we touched on before. This occurs in 100% of people over time. We see this every day. This in and of itself does not cause low back pain. We often see patients with severe degenerative disease who are completely pain-free. So degenerative disc disease is not an indication necessarily for surgical intervention or even pain management intervention, unless it's associated with one of the other conditions that I was talking about. So I want to now switch gears to talk about spinal deformity. So when we talk about spinal deformity, we're talking about a deviation in the normal alignment of the spine. And when we talk about the alignment of the spine, we talk about the coronal plane, which is basically when you're looking head on at someone's spine. And what you see is an abnormal curvature. This is an X-ray in the top right, and an overlay of a cartoon which would show what that abnormal curvature would look like. This is due generally to an asymmetric collapse of the discs, where one side of the disc collapses more than the other. The bone then becomes remodeled. This can also be due to a dysfunction in those thick erector spinae muscles, which then no longer are supporting the structures of the spine, and it has to do significantly more work. A degenerative scoliosis, such as this one, can progress up to 30 degrees per year, which is quite significant. As if it does progress at 30 degrees per year, you can have quite a severe deformity in a short amount of time. The other deformity that we typically refer to is a flat back deformity. So each region of the spine, the cervical, thoracic, and lumbar, has to have a certain curvature to it in order to maintain the normal gaze. And if you're unable to if you're unable to maintain the normal gaze, you're going to change your posture in order to look ahead. So when we see this loss of what's called the lumbar lordosis and a flattening of the spine, it can be caused either by degenerative disc disease and a flattening of that curvature, or this is one of the problems that's caused by that can be caused by surgical intervention. For example, in a long segment fusion surgery such as this one, if the curvature is not maintained, then that patient will suffer from a flat back deformity. And I'm sorry, I said progresses at 30 degrees per year. It should be 3 degrees per year, not 30. 30 degrees would be way too much. So this is just a small video showing. So the human body likes to, The human body likes to operate in what's called the cone of economy. And this cone of economy allows us to maximize our energy. And so when you can see when you travel outside the cone of economy, it puts significant pressure on the muscles in the lower back, as well as the muscles in the hip girdle and in the pelvis. And you have to expend a significant amount of energy in order to try and keep your posture when you're outside of this cone of economy. So as the spine degenerates and becomes flatter, patients tend to leave this cone of economy, and the way they try and compensate is to tilt their pelvis back, and that allows the gaze to remain horizontal. But as they do that, they continue to expend significant energy. The next step is that patients bend their knees in order to flex the pelvis backwards. That also causes a significant increase in the amount of energy that's required. That is why patients who have flat back deformities end up using a walker, because they can lean forward outside of their cone of economy and not necessarily expend the same amount of energy as they would if they were attempting to maintain that horizontal gaze without this device. So the treatment for spinal deformity is significant. This generally requires multiple segments of fusion and realignment. So patients have to exhaust every possible non-surgical treatment in order to be a candidate for this type of surgery. They have to be deemed healthy enough in order to undergo a rather large, significant surgery. These can take several hours, and patients tend to spend several days in the hospital. The recovery from this surgery is very long. It can take up to a year to fully recover from this type of operation. That course can be complicated by multiple other factors that can sometimes require revision surgeries. So this is not a problem that is taken lightly, and surgeons who recommend this surgery don't tend to do so in nonchalantly. We have to take all of the factors, including the health of our patients, into account when we're doing this type of large corrective surgery. The main goal would be to stabilize the spine, prevent it from collapsing any further, and reestablish that main curvature in the lower back in order to allow patients to stay in their cone of economy and increase their overall quality of life. Patients who do end up having the surgery after their long recovery period, they end up doing very well, but it is sometimes a very rocky one. So I just wanted to say thank you very much for having me and allowing me to talk to you, and I'm happy to answer any questions.
Great, thank you so much. And as a reminder, if anyone has questions, please put them within the chat window. And we did get a question about the recording being available, and Elena, I believe you're going to be sending that out, correct? Great. Okay, so this first question asks, it's about someone who's experiencing lower back pain, and they're saying that it occurs when they're standing after 5 to 8 minutes. They said that there's no leg pain and no pain when sitting, but when standing, the pain gets severe after 5 to 8 minutes, and it starts in their lower back and goes up to their shoulder and neck, and they have to sit down to relieve it. So they're wondering what might be causing that, and also if you have any recommendations for possible treatments. They said that they've explored injections in the past and they haven't really worked.
Okay. Without necessarily seeing the patient and without seeing any of the imaging, it's hard to make a strict diagnosis. However, based on the overall pain syndrome, that sounds like somebody who has, basically a disc problem that and may actually be contributing to a stenosis problem as well. Pain with standing for prolonged periods of time can also be due to muscle dysfunction. So it would be difficult to say exactly what's causing it without necessarily looking at the imaging, but most likely that would be a disc problem.
Great, thank you. Another question is that I know you've mentioned injections as a possible treatment option for various conditions. Do people typically require just one injection, or is it a long-term treatment that people get prescribed?
So generally, injections are done as a series of 3. You're only allowed to get 3 injections in the span of a year before you end up getting referred to for another treatment. So it's not a chronic long-term solution for patients to be getting several injections over their life.
Great, thank you. Another question's asked, does, and I may butcher this word, spondylolisthesis always require surgery?
It doesn't always require surgery. Sometimes as that disc collapses and the bones can actually fuse together on their own, and that motion will stop on its own without necessarily requiring a surgeon's intervention.
Perfect. Another question came in. They're wondering if you can discuss the benefits, or if you have a viewpoint on the benefits of seeking a chiropractor or acupuncture to help treat back pain, as well as Botox for potential muscle spasms in the back.
So acupuncture is very useful. No one outside of Chinese medicine really understands exactly why it works, but it is very effective in allowing patients to, have significant pain relief. As far as chiropractor goes, I would not recommend adjustments. However, a lot of chiropractors do massage and other sorts of therapy, which are very beneficial, but I wouldn't recommend any of the adjustments or cracking or anything like that. And then what was the third part?
The third part was they're wondering if Botox is effective for muscle spasms in the back.
So Botox is typically not used in the lumbar region. Typically, it's only used in the cervical region. A lot of our neurology colleagues do that type of procedure, and it helps with the muscle spasms in the neck. It's not particularly effective with problems in the lumbar region.
Great, thank you. The next question is about someone who is experiencing pain in their neck, and they're wondering if that could be attributed to spine problems. They had decompression surgery for spinal stenosis 2 weeks ago, but the pain in the neck is remaining, and they're wondering if that could be still related to their spine issue and their recovery, or if that could be related to just something else.
So typically, if you have an issue in the lower back, you also have issues in the neck with regards to degenerative disease and stenosis. So that's someone who likely has disc problems in the neck as well as in the lower back, what we refer to as a double crush phenomenon.
Another participant is wondering if you're familiar with the verti-lift process or procedure to relieve a pinched nerve issue. They said it seems to be used in people who cannot have surgery to correct their spinal issues. So I guess they're wondering if you have a viewpoint on that as a treatment.
So I believe that particular procedure involves implanting a small device with between the spinous processes of in order to basically force the patient to lean forward. It tends to provide good short-term relief, but long-term does not really help, and actually has a lot more adverse side effects than long-term relief.
A more general question is, if you are experiencing back pain, at what point should you look to seek care and get an opinion?
Basically, when it's affecting your overall quality of life. If the first thing you do when you wake up in the morning is think about the pain, and the last thing you think about before you go to bed is the pain, then you should probably seek some kind of advice. If you are not doing things because of the pain, such as you cancel vacations or trips or something like that because of the pain, if you don't go for your normal evening walk because of the pain, it's probably worth seeking some kind of advice.
That is great to know. And if you are deciding to seek care, is it best to go to a neurosurgeon first? Should you seek out your primary care, or is there someone else that should be kind of your first line of defense to help you evaluate what you're going through?
So generally, I recommend seeing a pain management specialist first, who specifically deals with spine problems. That can come from two different sources. One is physical medicine rehabilitation. The other one is anesthesia pain management. And they have expertise in diagnosing problems with the spine and then the non-surgical treatments, and then rely on them to refer you for surgical intervention if that's what's required.
Great, that's so helpful. I think that, I was going to say, I think we're all set on questions, but we just got one that came in. This person's wondering if you typically see good results by using an artificial disc, and if that's something that you use in your practice.
So artificial lumbar discs are not useful. The initial ones started in the early 2000s. And what ended up happening is that the artificial discs have more degrees of freedom than the actual native human disc. So essentially putting in a false disc in the lumbar spine caused instability in the back, and those patients ended up having worsening facet arthritis and more pain. Artificial cervical discs are useful, are used, but infrequently. They have a very strict indication for patients who have no bony overgrowth and only a soft disc herniation with isolated arm pain. So their indication is very strict. So the answer is not really.
Another quick question came in wondering if you have pain management physicians within your office.
We do. We have two pain management physicians here at UTHN who are experts in treating all problems of the spine.
Great, thank you. Okay, another question came in. They're wondering about their mom, who was diagnosed with cervical radiculopathy. Sorry if I mispronounced that. And the day of her surgery, the pain seemed to go away. She still gets random pains in her left arm and neck and has had steroid injections before. They're wondering if you have any suggestion on possible treatment options, and if you think there could be a connection or side effect of having ringing ears, which I guess this person might be experiencing. She never did go through with her surgery because the pain went away.
Yeah, so that's a very common thing that we see, is that the pain is pretty intermittent. Cervical radiculopathy is something that's treated pretty well with physical therapy, particularly traction therapy, in which basically the neck is expanded, and that allows the little holes where the nerves are exiting to be free. It's likely not related to the ringing in the ears. That the ringing in the ears is generally caused by the eighth cranial nerve, which comes directly out of the brain.
Perfect. Another one came in. Do your pain management doctors see workers' compensation patients?
Yes, they do.
Okay, well, Dr. Caridi, thank you so much. I think that takes us to the end of the Q&A. And Elena, I want to thank you for having us.
Absolutely. And again, thank you to Dr. Caridi and UTHealth Neuroscience for sponsoring us. All of you on the call, stay tuned, because we are very fortunate once a month to have a timely medical presentation from one of their physicians. Everybody stay safe and have a good rest of the day and a great week. Bye-bye now.
Thank you.